Welcome to this deep dive. Today we're honing in on head and facial anatomy, along with key surgical principles relevant for board preparation. We'll cover structure, vascular supply, muscles, dentition, anesthesia, infections, and deformities. Let's start with the basic divisions of the head.
Right. So we broadly divide the head into the neurocranium, which protects the brain, and the visceral cranium. That's the part associated with functions like breathing, smelling, eating, and talking.
And the visceral cranium itself has specific regions.
Yes, 5 key regions: the orbital region, the infratemporal and temporal fossae, the nasal region, the maxilla, and the mandible.
Okay. Moving to vascular supply, how do these two main divisions get their blood?
Well, the neurocranium is primarily supplied by the internal carotid and the vertebral arterial systems. The visceral cranium, on the other hand, mostly relies on the external carotid system.
Mostly. Is there overlap?
There is. It's important to remember that structures in the midline, like the forehead and midface, actually benefit from a dual vascularity, getting contributions from both the internal and external systems. And venous drainage.
Primarily via the internal jugular vein. But you also have significant contributions from the face draining through the facial, retromandibular, and external jugular veins, which then feed into the larger system.
Understood. Let's talk about the muscle groups associated with the visceral cranium functions.
Okay, there are 6 major groups we should cover. First, the orbital muscles. These are both intrinsic within the eye and extrinsic controlling eye movement.
Right. And second?
Second is the masticatory group. These are your chewing muscles, the temporalis, the medial and lateral pterygoids, and the masseter.
The muscles of mastication. Okay, third group.
Muscles of facial expression. This is a large group, includes things like frontalis, orbicularis oculi around the eye, orbicularis oris around the mouth.
Zygomaticus major and minor for smiling.
Exactly. And levator labii, depressor labii, the buccinator in the cheek, mentalis in the chin, and the platysma extending down into the neck. They allow for all our facial movements.
That covers quite a bit. What are the remaining 3 groups? Fourth, the tongue muscles, critical for speech and swallowing. These are intrinsic, changing the tongue shape like the superior and inferior longitudinal, transversus, and verticalis muscles.
And extrinsic.
Yes, the extrinsic muscles move the tongue's position. That's the genioglossus, hyoglossus, styloglossus, and palatigloss.
Okay, 5th group.
The pharynx muscles, primarily the constrictor superior, middle, and inferior involved in the swallowing process.
And finally, the 6th group.
Lastly, the larynx muscles. While we often think of them for voice production, they're an integral part of the head and neck musculature we consider.
Good overview. Let's focus now on the oral cavity. What defines its boundaries and what are some key structures within it?
Sure. The oral cavity technically extends from the oral aperture of the lips back to the palatoglossal fold. Key structures you need to know include the duct openings for the major salivary glands.
Like Wharton's ducts.
Precisely. Wharton's ducts drain the submandibular and sublingual glands, opening onto the floor of the mouth. And then you have Stenson's ducts.
For the parotid gland.
Correct. Stenson's ducts drain the parotid glands and open onto the buccal mucosa, typically opposite the maxillary second permanent molar. You need to know that location.
Definitely. Let's switch gears to dentition. What are the key differences between pediatric and adult teeth?
Pediatric or primary dentition has 20 teeth. We typically letter them A through T. Per arch, that's 4 incisors, 2 canines, and 4 molars.
And importantly,
There are no premolars in the pediatric dentition.
okay, and adult dentition.
Adult or permanent dentition consists of 32 teeth. These are numbered 1 through 32. Each arch has 4 incisors, 2 canines, 4 premolars, there they are, and 6 molars, including the third molars or wisdom teeth.
What about extra teeth?
If someone has supernumerary teeth, they're numbered starting from 51, so 51 through 82.
Good to know. Can you outline the typical eruption sequence for permanent teeth? It's often tested.
It is. The first permanent teeth to erupt are usually the first molars around age 6 to 7. Then come the incisors, generally between 6 and 9 years.
Okay, molars, then incisors.
Then the canines, typically between 9 and 12 years. Following them are the first premolars, around 10 to 11 years, and the second premolars, around 11 to 12 years.
So premolars come after canines.
Usually, yes. Then the second molars erupt between 11 and 13 years. And finally, the third molars, if they erupt, typically appear between 17 and 21 years.
Is there anything specific about the maxillary canine timing?
Yes, it's worth noting that the maxillary canine, the upper eye tooth, often erupts after the maxillary lateral incisor and the first premolar have already come in, so it sort of wedges its way in later.
Right. Let's cover some essential dental terminology, starting with Surfaces.
Okay. Occlusal refers to the chewing surface of posterior teeth, molars, and premolars. Incisal is the term for the biting edge of anterior teeth, incisors, and canines.
And directions relative to the tooth itself.
Apical means towards the root tip. Mesial means towards the midline of the dental arch. Distal means away from the midline.
Okay, mesial towards the front center, distal towards the back.
Correct. Then buccal refers to the surface facing the cheek. Lingual is the surface facing the tongue, specifically for mandibular teeth.
And for maxillary teeth facing the palate.
That's termed palatal.
Got it. What about the relationship between upper and lower teeth? Overbite and overjet.
Overbite is the vertical overlap of the upper incisors over the lower incisors when biting. Overjet is the horizontal distance between the facial surface of the lower incisors and the incisal edge of the upper incisors. Think of it as the horizontal projection.
Vertical overlap is overbite. Horizontal distance is overjet. Okay. A few more terms.
Sure. Proclined means the tooth is angled forward towards the lips. Retroclined means it's angled backward towards the tongue or palate.
And tooth positioning.
Buccal version means a posterior tooth is positioned more towards the cheek than normal. Lingual version means it's positioned more towards the tongue or palate.
What's a crossbite?
A crossbite occurs when one or more maxillary teeth are positioned lingually or inside their opposing mandibular teeth when the jaws are closed. It can be anterior or posterior.
And an open bite.
An open bite is simply a lack of occlusal contact between opposing teeth when the jaws are in centric occlusion. There's a gap.
Okay. Two final terms. Centric occlusion and centric relation.
Centric occlusion, or CO, is the position where there's maximal interconspation of the teeth, basically how the teeth fit together best. Centric relation, or CR, is a jaw relationship, not a tooth relationship. It's defined by the position of the mandible relative to the maxilla when the condyles are in their most anterosuperior stable position within the glenoid fossa.
So CO is about teeth fit, PR is about condyle position.
Exactly. They don't always coincide in every patient.
This leads us to malocclusion. How is it defined, and what is Engel's classification?
Malocclusion is essentially any deviation from the ideal normal occlusion. Engel's classification is based on the relationship between the maxillary and mandibular first permanent molars.
What constitutes normal occlusion in this system?
Engel defined normal occlusion, what he called class I occlusion, as the mesiobuccal cusp of the maxillary first molar fitting neatly into the buccal groove of the mandibular first molar. Crucially, all other teeth should also be aligned smoothly without rotations or significant malpositions.
So class I isn't just the molar relationship.
Correct. True normal occlusion requires both the class I molar relationship and proper alignment of all other teeth. You can have a class I malocclusion.
Ah, okay. So what defines a class I malocclusion then?
Class I malocclusion means the molar relationship is normal, that mesiobuccal cusp is in the buccal groove, but there are other problems like crowding, spacing, rotations, or other malpositions of the teeth. So normal molar relationship, but not normal overall occlusion.
I see. And class 2?
Class 2 malocclusion is characterized by the mandibular first molar being positioned distally or further back relative to the maxillary first molar. The mesiobuccal cusp of the maxillary molar is mesial, or forward, of the buccal groove of the mandibular molar.
And class 2 has subdivisions?
Yes. Division 1 and Division 2. Class 2 division typically shows excessive overjet. The upper front teeth stick out quite a bit, but the incisors themselves might have a relatively normal inclination.
Okay. And Division 2?
Class 2, Division 2 is different. Here, the maxillary central incisors are often retroclined, tilted backward. There might be less overbite or even a deep bite, but the overjet can still be increased, especially involving the lateral incisors.
Retrocline centrals define Division 2. And finally, class 3?
Class 3 malocclusion is the opposite of Class 2. The mandibular first molar is positioned mesially, or further forward, relative to the maxillary first molar. The mesiobuccal cusp of the maxillary molar falls distal, or behind the buccal groove of the mandibular molar, often associated with an underbite or reverse overjet.
Got it. Molar relationships are key. Let's transition to local anesthesia techniques for the head and face. What are the main approaches?
Broadly, you have regional nerve blocks where you anesthetize a specific nerve trunk, and local infiltration where you anesthetize terminal nerve endings in a specific area.
When would you choose one over the other?
Well, for mandibular teeth, nerve blocks, specifically the inferior alveolar nerve block, are generally necessary. This is because the cortical bone of the mandible is quite dense, making infiltration less effective at reaching the nerve supply to the teeth.
Whereas in the maxilla,
The maxillary bone is more porous, so infiltration can often be effective for anesthetizing individual teeth or small areas, although blocks are still used for wider coverage.
Are there important safety points regarding needles?
Absolutely. Routine bending of needles before injection should generally be avoided as it can weaken the needle. Also, critically, a needle used to inject into an infected site must not be reused for subsequent injections in non-infected areas to prevent spreading the infection.
Makes sense. Let's detail some specific blocks. The infraorbital nerve block.
Okay, the infraorbital nerve block targets the infraorbital nerve as it exits the infraorbital foramen. You need to know the location. Typically 4 to 7 millimeters below the inferior orbital rim, vertically aligned with the medial limbus of the eye when the patient looks straight ahead.
How is it performed, and what does it numb?
It can be done intraorally or extraorally. It provides anesthesia to the upper lip, the medial part of the cheek, the lower eyelid, and the lateral side of the nose on that side. It also covers the buccal gingiva from the midline, usually back to the second premolar, and often the teeth in that area through diffusion of the anesthetic.
Okay. What about blocking sensation on the palate? The greater palatine nerve block.
The greater palatine nerve block targets the nerve as it emerges from the greater palatine foramen. This foramen is usually located on the hard palate, about halfway between the gingival margin of the maxillary molars and the palatal midline, typically near the second molar. You can often palpate a slight depression there.
And the area of anesthesia.
This block anesthetizes the posterior palatal mucosa and gingiva on that side, from the maxillary tuberosity forward to about the first premolar area, where it meets the area covered by the nasopalatine nerve.
Let's cover that one next, the nasopalatine or incisive nerve block.
Right. The nasopalatine block targets the nasopalatine nerve as it exits the incisive foramen. This foramen is in the midline of the anterior hard palate, just behind the maxillary central incisors, usually about 5 to 7 millimeters back, often covered by the incisive papilla.
And this covers.
This block provides anesthesia to the anterior palatal mucosa, essentially from canine to canine.
Okay, moving to the mandible now.
Yeah.
The inferior alveolar nerve block, the workhorse block.
Indeed. This targets the inferior alveolar nerve just before it enters the mandibular foramen on the medial aspect of the ramus. The landmarks are critical here.
Can you describe them?
The foramen is usually about 5 to 10 millimeters superior to the occlusal plane of the mandibular teeth and about 15 to 20 millimeters posterior to the anterior border of the ramus.
And the technique generally.
A common technique involves palpating the coronoid notch with the contralateral thumb to gauge the height. The needle is inserted from the opposite side of the mouth, aiming towards the medial ramus about 10 millimeters above the occlusal plane, often at roughly a 45-degree angle to the sagittal plane, advancing until bone is gently contacted.
What area does this block cover?
It's extensive. It anesthetizes all the mandibular teeth on that side, molars, premolars, canine, incisors. It also covers the buccal soft tissues and gingiva anterior to the mental foramen, so roughly from the second premolar forward, via the mental nerve branch.
What about the lingual nerve? Is it blocked separately?
Often, it's anesthetized during the same injection as the inferior alveolar nerve. After contacting bone for the IAN block, you typically withdraw the needle slightly, maybe half a centimeter, and deposit a small amount of additional anesthetic. The lingual nerve runs nearby.
What does the lingual nerve block cover?
It anesthetizes the entire lingual gingiva and mucosa on that side, the floor of the mouth, and the anterior two-thirds of the tongue on that same side.
Okay. There's also a buccal nerve block sometimes needed.
Yes, the long buccal nerve block. The inferior alveolar block doesn't cover the buccal gingiva adjacent to the mandibular molars. So if you need anesthesia there, for example, for an extraction, you need this separate block.
How's that done?
It targets the long buccal nerve as it crosses the anterior border of the ramus in the retromolar area near the external oblique ridge. You typically inject into the mucosa, just distal and buccal to the last molar.
And this covers the buccal gingiva near the molars.
Correct. It anesthetizes the buccal mucosa and gingiva overlying the mandibular molars and sometimes premolars, usually back to the first premolar region where the mental nerve block area begins.
Lastly, the mental nerve block.
The mental nerve block targets the mental nerve as it exits the mental foramen. This foramen is usually located below the apices of the mandibular premolars, often between them or below the second premolar.
Technique and area covered.
The technique often involves retracting the lip and inserting the needle into the mucobuccal fold near the premolar apices. It provides anesthesia to the buccal gingiva anterior to the foramen, the lower lip, and the skin of the chin on that side.
Is it always necessary?
Usually not if you've performed a successful inferior alveolar nerve block, because the mental nerve is a terminal branch of the EAN. But it can be useful for isolated procedures on the anterior buccal gingiva or lower lip without numbing the whole jaw.
Excellent overview of the blocks. Let's turn to odontogenic infections. How serious can these be?
They range widely from simple localized abscesses to potentially life-threatening infections involving deep fascial spaces. Despite antibiotics, mortality still occurs, often due to airway compromise or spread into the mediastinum. So accurate evaluation is crucial.
What kind of organisms are typically involved?
These are almost always polymicrobial infections. You typically see a mix of aerobic gram-positive cocci, like Streptococcus species, anaerobic gram-positive cocci, like Peptostreptococcus, and various anaerobic gram-negative rods, such as Prevotella, Porphyromonas, and Fusobacterium species. It's a mixed bag.
How do these infections usually start? What's the pathogenesis?
There are two main pathways. Periapical infections arise from pulpal necrosis. The nerve inside the tooth dies, gets infected, and the infection spreads out the apex, the root tip. This is the most common route.
And the second pathway?
Periodontal infections. These originate from deep periodontal pockets alongside the tooth root, associated with gum disease.
How does the infection spread from the tooth into the surrounding tissues?
Once the infection, usually periapical, erodes through the cortical bone surrounding the tooth root, its path is determined largely by the location of the perforation relative to muscle attachments.
Could you give an example?
Sure. Take the mylohyoid muscle, which forms the floor of the mouth. If an infection perforates lingually from a mandibular premolar, whose root apex is typically above the mylohyoid attachment, the infection will likely present in the sublingual space.
And if it's from a molar?
If the infection perforates lingually from a mandibular second or third molar, whose root apices are usually below the mylohyoid attachment, the infection is more likely to track into the submandibular space. Those muscle attachments are key directors of spread.
Very important point. What are the core principles for managing these infections?
First, a thorough history and physical exam are essential to determine the severity. You need to look for systemic signs: pyrexia, tachycardia, hypotension. Assess the airway carefully, any stridor, difficulty swallowing. Look for trismus, which indicates involvement of masticator or parapharyngeal spaces.
What else is key in the initial assessment?
Identifying the source tooth, usually with clinical exam and radiographs, like a panoramic or periapical film. Examining the fascial spaces, clinically swelling, tenderness, fluctuance. And importantly, assessing the patient's host defenses. Are they immunocompromised from diabetes, medications, or other conditions?
Once assessed, what's the primary treatment intervention?
After securing the airway if necessary, surgical drainage is the most critical intervention for any significant odontogenic infection involving fascial spaces. Prompt and adequate drainage is key. Specialist involvement, like OMFS or ENT, might be appropriate depending on the severity and spaces involved.
And the role of antibiotics.
Antibiotics are an important adjunct to drainage, but not a substitute for it in cases of abscess or space infection. Ideally, you'd get cultures during drainage to guide therapy.
What about empiric coverage initially?
Empiric therapy is usually started immediately. Penicillin or amoxicillin are often first-line choices, given the typical pathogens. Clindamycin is a common alternative for penicillin-allergic patients. For severe infections, broader coverage might be needed initially, then tailored based on culture results.
Okay, let's discuss arch bars now. What are their main uses in trauma and surgery?
Arch bars are used primarily for a few key reasons: to stabilize dentoalveolar fractures or even some mandibular fractures, to serve as a stable base for applying maxillomandibular fixation, MMF, and to help control and maintain the patient's occlusion during fracture reduction or orthognathic surgery.
Are they always easy to place?
Not always. Placement difficulty can depend on the state of the dentition, things like very young or very old teeth, partial edentulosum making it hard to get purchase, or significant dental decay or mobility.
Where are they typically placed, and how far should they extend?
Usually they span from the first molar on one side to the first molar on the other side in both arches. For mandibular fractures, ideally the bar should extend at least 2 sound teeth beyond the fracture line on either side to provide adequate stability.
How are they secured?
They're wired to the teeth using circumdental wires, typically 25-gauge stainless steel wire.
Are there specific principles for wiring?
Yes. Wires are usually tightened in a clockwise direction. In an interproximal space that crosses a fracture line, the wire loop should pass occlusal to the arch bar to help compress the fragments. Similarly, distal to the last tooth or across a dentulous spans, the wire goes occlusally.
And the sequence.
Wiring often proceeds from the midline posteriorly on both sides. Using a gauze director or a specialized instrument can help guide the wire underneath the height of contour of the tooth interproximally.
What's critical before final tightening?
Ensuring the occlusion is correct and any fractures are properly reduced before fully tightening the MMF wires or the circumdental wires holding the arch bar itself is paramount. Lock things in the wrong place and you cause problems.
Is there an alternative to traditional arch bars?
Yes, systems like the SmartLock Hybrid MMF system exist, which use bone-supported screws and connecting plates instead of wiring around the teeth. They can be quicker and potentially less traumatic to the periodontium.
Interesting. Let's move into the realm of dentofacial deformities. What's the general concept here?
Dentofacial deformities involve underlying skeletal discrepancies of the maxilla, mandible, or both, which affect both facial aesthetics and dental occlusion. Treatment usually requires an integrated approach involving both orthodontics and surgery.
Can orthodontics alone fix these?
Sometimes, simple orthodontics can camouflage a mild skeletal discrepancy by moving the teeth to compensate. However, for significant skeletal issues, surgery is often needed to correct the underlying bone structure. Early involvement of the surgeon in planning is really crucial.
What's the goal of the pre-surgical orthodontic phase?
The main goal is to decompensate the dentition. This means reversing any natural dental compensations that have occurred to mask the skeletal problem. The orthodontist aims to align the teeth properly within each jaw's bone base, setting them up for the correct position after the jaws are surgically moved. Essentially, making the bite look worse before surgery makes the surgical result better and more stable.
What specific things are assessed during the dental evaluation for these deformities?
The dental evaluation looks for clinical signs of the skeletal discrepancy. This includes identifying transverse issues like crossbites, anteroposterior problems reflected in the angle classification and overjet, and vertical problems like open bites or deep bites. We also assess tooth size discrepancies, excessive curves in the arches like the curve of Spee or curve of Wilson, and any canting or tilting of the occlusal plane.
Cephalometric analysis is also key, right?
Yes, cephalometric evaluation uses standardized lateral skull radiographs to take specific angular and linear measurements. These help quantify the relationships between the skull base, the maxilla, and the mandible, assess dentofacial proportions, and pinpoint the skeletal basis of the deformity.
Is the cephalometric analysis the sole guide for surgery?
No, it's a crucial diagnostic tool, but it shouldn't be the only factor driving the surgical plan. The final surgical decisions are heavily based on the clinical aesthetic evaluation, considering facial balance and harmony, after the cephalometric diagnosis helps understand the underlying issue.
You mentioned an example.
Yeah, for instance, a patient might have cephalometric findings suggesting mild mandibular prognathism, but aesthetically they might achieve much better facial balance with a maxillary advancement rather than a mandibular setback. The clinical look guides the choice.
Can you list a few key cephalometric landmarks, soft and hard tissue?
Sure, some common soft tissue landmarks are glabella prime, GA, subnasal, SNS, labial superius, LS arrow, labial inferius, lay, and soft tissue pagonian, PGA. Hard tissue landmarks include sella S, nation N, orbital O, interior nasal spine, ANS, posterior nasal spine, PNS. Points A and B representing the maxillary and mandibular alveolar bases, menton, me, gonyan, go, and articular, arfa. There are many others, of course.
And the aesthetic evaluation itself focuses on?
It looks at the face from both frontal and profile views. We analyze vertical proportions, typically dividing the face into thirds, upper, middle, lower, and horizontal symmetry and balance. The goal is achieving harmony between all facial components.
Let's talk through some general diagnoses. Maxillary excess.
Maxillary excess can be anteroposterior, vertical, or transverse. Vertical maxillary excess, or VME, often presents with a long lower facial third, sometimes a narrow nose base, excessive display of the upper incisors and gums when smiling, gummy smile, lip incompetence where the lips don't meet at rest, and possibly an anterior open bite.
And anteroposterior excess.
Anteroposterior maxillary excess usually manifests as a class 2 malocclusion, protruding maxillary incisors, and a convex facial profile. The primary surgery for most types of maxillary excess is typically a Le Fort eye osteotomy to reposition the maxilla.
What about the opposite, maxillary deficiency?
Maxillary deficiency, again in any dimension, can lead to features like deficiency in the infraorbital rim and paranasal areas, making the midface look flat, inadequate show of the upper teeth at rest or on smiling, sometimes a short lower facial third appearance, and a deficient-looking upper lip.
And the surgery.
Again, the primary surgical correction is usually a Le Fort eye osteotomy, but this time to advance or move the maxilla down. Bone grafting might be needed, especially for significant advancements.
Moving to the mandible. Mandibular excess or prognathism.
This typically presents with a class 3 molar and canine relationship, often a reverse overjet, lower teeth in front of upper teeth, and a prominent lower facial third and chin.
How is it corrected?
Correction might involve maxillary advancement, mandibular setback, or a combination. Common surgical procedures for mandibular setback are the bilateral sagittal split osteotomy, the SSO, or the intraoral vertical ramus osteotomy, IVRO.
Are there key differences between BSSO and IVRO for setbacks?
Yes, IVRO generally requires a period of maxillomandibular fixation post-operatively, while BSSO usually allows for earlier function but carries a higher inherent risk of injury to the inferior alveolar nerve.
Okay. And mandibular deficiency or retrognathism.
This is characterized by a class 2 molar and canine relationship, often with excessive overjet or a deep bite. Facial features include a retruded chin, often an acute or deep labiomental fold below the lower lip, abnormal lip posturing to achieve seal, and potentially a short thyromental distance, which can have airway implications.
Primary surgery for deficiency.
The main surgical treatment for mandibular deficiency is mandibular advancement, almost always performed via a BSSO.
Finally, how stable are these corrections long-term? What influences relapse?
Stability varies. Factors influencing potential relapse include which jaw was moved. The direction of movement advancements are generally more stable than setbacks, large movements less stable than small ones. Orthodontic factors matter too, like inadequate removal of dental compensations before surgery or incomplete arch leveling.
And surgical factors.
Surgical technique plays a big role. Inaccurate positioning of the bone segments, especially the proximal segment containing the condyle and a BSO, inadequate or unstable fixation, and sometimes unpredictable biological factors like idiopathic condylar resorption where the condyles shrink after surgery, particularly in certain patient groups.
A lot to consider for stability. To wrap up, let's quickly reiterate a few high-yield points from our discussion.
Okay, key muscles of mastication to absolutely know. Temporalis, medial and lateral pterygoid, and masseter. Remember, Stenson's duct opens opposite the maxillary second permanent molar, pediatric dentition, 20 teeth, no premolars, lettered AT. Adult dentition, 32 teeth, numbered 132. And critically, angle class malocclusion has the normal molar relationship, but it isn't necessarily normal occlusion overall because other teeth can still be malposed.
Excellent summary. A solid grasp of this head and facial anatomy, the dental principles, local anesthesia, infection management pathways, and the assessment and treatment concepts for dental facial deformities is really fundamental for residents preparing for boards in practice. This deep dive aimed to consolidate that foundational knowledge. We strongly encourage you to review your source materials for further detail.